Good morning, everyone. I'm sorry I had some technical difficulties, some complications in my own presentation here. Thank you, Dr. Narayanan, for giving me this opportunity for giving this instruction course on preparing the postgraduate to tackle complications in a slightly variated way. So let's start with one of the few complications which generally we see in our daily postgraduate training, which could be scleral buttonholing of a scleral tunnel, an intermittent cataract, which can turn out to be an Argentinian flag, a PC rent, an iridodialysis, or even hyphema because of iris manipulation. So, first, what do we know and what have we learned? So, whenever a PG makes a mistake, do not reprimand them, just encourage them, sit with them, go through the steps. If they have a video, just show them the video, show them where they have gone wrong, and help them understand how to proceed further. And always make sure you have a backup plan when you have a complicated case. So, when you have a backup plan, you try to stay calm, and then staying calm helps you avoid making any cloud your judgments and proceed in a easy way. And if everything doesn't go well or go south, just pray harder and hope you have some friends in the VR department. So when you have any so usually PGs can start off with a well dilated pupil, but due to some iris manipulation, the pupil can undergo an intraopmyosis. So initially, we can start off with a simple sphincterotomy, which could be a radial sphincterotomy or micro sphincterotomies, which can give you a well dilated pupil to deliver the lens. Next, you can start implanting iris hooks. Iris hooks can be initially difficult, but then as you start training them, they can understand how it works. So this is something which we started training our PGs. This is an Gupta ring, no financial interest. So Gupta ring can have four scrolls. You just have to flex the scroll into the cartridge. It could be an IOL cartridge, and after which it is it can be injected into the anterior chamber just like an IOL, but just make sure that the plane of insertion is under the iris and does not go into the sulcus. And use visco to form the anterior chamber. And the other scrolls, make sure the first scroll goes underneath, and the rest of the scrolls can be guided through using a second instrument, which could be a dialer or a Y hook or a phaco tip of, a phaco rod. So as you can see, you can get a well dilated pupil, after which you can proceed with either a phaco or an SICS. So here we have a resident who inadvertently ruptured the capsule. You can see that after applying the dye, there's an Argentinian flag. So what we did, we continued with an SICS. We just entered the anterior chamber, form the AC with some amount of sodium hyaluronate, and deliver the nucleus using the anterior capsule rim as a scaffold. And after which you can just insert or implant the IOL. After implanting the IOL, you can trim the anterior capsular rim. This will give the patient a good visual quality of life, avoid any form of anterior capsular phimosis or contraction syndrome. So always have a backup plan, like I said. When a postgraduate starts off training for phaco, he might go through any complications such as the runout rexes or any form where you might have to change over to convert to an SICS or an ECC. So this is a simple, innovative way where you just continue the phaco wound, make radial cuts, back end cuts, and include the phaco wound into your tunnel. So this way you avoid any new incisions, have a good anterior chamber, there is no iris prolapse, and you after postoperatively you tend to have a smaller astigmatism. You can see that we are proceeding with a regular scleral groove here and including the original phaco incision tunnel. Make sure you make nice scleral pockets so that the delivery is easy. And the rest is the usual. So, oftentimes you can see that there is a zonular weakness due to pseudo exfoliation or any other manipulation during intraop. So, this is where we insert in CTR. So, in a beginner's hand for a postgraduate, there could be difficulties in inserting a CTR. So, this is a easy way where you just thread the CTR into a CTR implanter, and after which, once it's inserted and threaded in, you're ready to implant it. And implantation is as easy as implanting. Yeah, so you just implant it into the under the anterior capsular rim, and make sure the insertion is away from the zonular weakness. And when you're inserting, use a second instrument so that you can guide the CTR into the right plane. So when you have a PCR, just hang in there like our hanging IOL technique, where we anchor a rigid IOL, in this case a three-piece rigid IOL. You just take the suture into the IOL dialing hole, after which you can implant the lens with full confidence. And if there's any instability in your capsular bag, you can always expand it out, use the free end of the suture to remove it. So if everything doesn't work out, what is next? You can claw your way out using an iris claw. So here again, we are anchoring the iris claw with a suture. So this gives the PG a little bit of confidence when inserting it. And it's also easy to enclave this iris claw. And on the right side, you can see that these are the iris, the orientation or you can see that there's a cat eye. Initially, a postgraduate can have a cat eye pupil. Later on, after a certain practice, he can get a well-rounded pupil. Okay, so finally we have this unusual complication, but we often tend to see this complication in our practice. So here we have an improper loading of an IOL, where you can see that there's a broken haptic once it's implanted inside the bag. So rather than removing the IOL just like that, or explanting or IOL cutting it, you can use another IOL to use the other IOL as a scaffold, implant the second IOL into the bag, and after which, I'm sorry. And when you're inserting the other IOL as a scaffold, you can cut the first primary IOL which you had implanted using an IOL cutting scissors. Oftentimes, when you cut the IOL slips forward. So use a secondary instrument such as a phaco ball tip dialer or any Y hook, so that you can grip the IOL and cut it. And after which you can remove it through a 4 millimeter or a 4.5 millimeter incision. So I hope these tips have given you some insights or ideas on how to train your PGs. And thank you for this opportunity.